We've just learned what LungVision is, and this is talking a little bit about that as well. What we really wanted to look at with this study is specifically looking at the CT-to-Body-Divergence. And so this wasn't specifically with LungVision, it was used in these cases, but what we wanted to do is take the preoperative CT scan that we all use to drive our navigation platforms, whether it's Veron and Superdimension or whatever. And so we know that there's a significant CT-to-body divergence there's a lot of new technologies coming out now that are highlighting that difference, and the ones that I find most important are the ones that have a fix for that and can correct for the CT-to-body divergence. We know that patient positioning changes, inspiratory and expiratory changes. There's been a lot of stuff published recently on this as well. And so basically what we did was we took a handful of these patients and we looked at their preoperative CT scan and then their intraoperative cone beam CT scan to compare the differences and calculate that CT-to-body divergence. And that accounts for a lot of the lower yields in electromagnetic navigation that we see. This is not an electromagnetic-based platform. But what we saw is that on average, about 23 millimeters difference in position between the preoperative CT scan and the intraoperative cone beam position during a breath hold. Interestingly, we did see that this was lower in the lower lobes, which is counter to some other evidence that's been out there, so we're a little surprised at that. However, there's significant motion difference in both the upper lobes and the lower lobes. So again, lung movement caused by CT to patient or CT to body divergence is significant, particularly compared to the target lesion size. If we're going after a 1 centimeter lesion, as is the case here, then being off by 2 centimeters is going to be a very big problem. So we want to focus on technologies that are able to compensate and correct for this CT to body divergence. Thanks.